Hi, I'm James Rippey, and I'm going to give you this lecture on early pregnancy ultrasound, level 1, which is basic ultrasound. Once again, it's a Saturday night at midnight. I find myself sitting in front of my computer, coffee in hand, and ready to go. So hopefully you'll find this useful, because most people on a night like tonight are out doing something a little more exciting. Having said that, I think early pregnancy ultrasound can really affect the way you manage patients, even if you only know a little bit about it, as long as you know and practice safely. In this lecture, I'm going to cover the training requirements that are needed to be skilled and appropriately knowledged in early pregnancy ultrasound. We're going to go through the broad objectives of early pregnancy ultrasound level 1. We're going to go through normal pregnancy and the changes that you see both in reality and on ultrasound. Then we're going to touch on integrating ultrasound into your clinical algorithms. We've all got clinical algorithms in our head, how we manage patients in early pregnancy. At the moment, any pregnancy problem gets a formal ultrasound or referral to an obstetrician generally. But this lecture is about integrating basic ultrasound knowledge into your clinical assessment, and that's what that section of this lecture is on. And finally, we're going to go through the early pregnancy ultrasound report, which is a pre-formatted report that you can use to help practice ultrasound safely in your practice. So let's start with the training requirements. The philosophy of level 1 ultrasound is, firstly, we feel that limited ultrasound knowledge is useful. We also think that a modular educational approach is very effective, as long as you ensure that there are appropriate structured educational processes in place. It's really important that people doing ultrasound understand their limitations. And one of the ways we do this is to use a pre-formatted report, which we've designed and we'll go through in a minute. The learning process for ultrasound that we think is effective is a structured modular approach, and that seems to be being accepted by clinicians around the world. That begins with getting background knowledge. In an ultrasound, that's a bit of physics and using the machine and how to perform a scan. Then you need knowledge and skill acquisition for the module that you're doing, and an approved course like this one is a way to do that. But there are lots of appropriate ultrasound courses for all sorts of modules, including early pregnancy, that are fine to get the basics on the knowledge and skill that you need to be able to do ultrasound. The next step, though, is consolidating that knowledge and skill. Just doing a course isn't enough. What I think you need to do, and what the general consensus around the world is, you've got to get a logbook with some scans in. Most people say that once you've done 25 scans of whatever module that you're doing, a very limited number of scans obviously, you can recognize some basic things. And I think 25 scans of patients in early pregnancy is probably enough to start reliably recognizing what's going on. I also think some formative assessments are very important. And again, this is not my personal thought, this is thought around clinical ultrasound teachers around the world. A formative assessment is a structured teaching tool whereby you do an ultrasound with an expert who goes through a stepwise process of making sure that you don't miss anything out and you understand what you're doing. It's like an intensive supervised ultrasound. So 25 scans independently by yourself of early pregnancy patients, 3 formative assessments. You can do any reading, go to conferences, courses, whatever you like. But the final stage is knowledge and skill assessment. And that's to make sure that you're actually safe and you've learned what you should have learned in the first 3 stages. And that can be tested using multiple choice examination, using image interpretation examinations, and with a summative assessment, which is just like a formative assessment, except the teacher doesn't help you on the way through. They don't educate you, they just test you. So that's the modular process that I think we all need to go through. The broad objectives of level 1 ultrasound. Early pregnancy ultrasound level 1, so basic, only aims to do a couple of things. Well, 4 things. The first is to confirm an intrauterine pregnancy. And most patients, in all honesty, who present with pain and bleeding in early pregnancy, you can confirm an intrauterine pregnancy. The patient's reassured, you're reassured, and you know that they're relatively safe. The next thing that we can do with level 1 ultrasound is confirm viability of that early pregnancy. If it's got a heartbeat, it's viable at that stage. The next thing we want to do is be able to assess for free fluid, because if there's lots of free fluid, it may well be an ectopic. And finally, we've got to have the clinical knowledge and ultrasound skill to be able to make appropriate management decisions according to the clinical situation. So we've got to understand what we're doing, basically. Indications for level 1 ultrasound: pain and bleeding in early pregnancy, obviously, but sometimes you get collapse in a female of reproductive age and you haven't got a pregnancy test off them, you can't get urine, they're in shock, and you need to quickly assess them. And one of the things that happens is they have an ectopic, they get a belly full of blood, they've got an empty uterus, and you can tell that very quickly. The other group is just checking for viability in very anxious patients, and we're often faced with that. And that is something we can do with not a huge amount of ultrasound education. There's a broad differential diagnosis for people who present with pain and bleeding in early pregnancy. It could be a viable pregnancy, in which case we call it a threatened miscarriage. It could be a miscarriage, and there are a number of different classifications, but a missed miscarriage is one of them, and that's where the miscarriage or the gestation sac remains in the uterus. It could be an incomplete miscarriage where some of the products of conception remain in the uterus, or it could be a complete miscarriage where the products are now out of the uterus. It could be an ectopic pregnancy, and there are all sorts of locations. They can be tubal or abdominal or cervical, interstitial or cornual, and even ovarian. Scar ectopics are also getting more common post-caesarean sections. And finally, gestational trophoblastic disease is a possibility for pain and bleeding in early pregnancy. This is the initial assessment algorithm that we're going to deal with and go through during this lecture. On the left-hand side, you can see that we start by assessing patients with history and examination. Then we go into ultrasound and check a beta HCG. There are a number of steps that we go through. If there are high-risk features, so ectopic's likely, they go off for a scan. If it's a definite miscarriage, we can deal with that. If it's a definite intrauterine pregnancy, we can discharge them. If it's an empty uterus, then things get more complicated. We'll need to go through this in more detail. Often after that initial assessment, one of the things you do is you get people back in 48 hours to repeat an ultrasound or have a full ultrasound and look at their beta HCG again. So there's a 48-hour follow-up algorithm that we'll also go through in this lecture. This is the early pregnancy ultrasound report that we've developed. You can see here at the top, level 1, early pregnancy. Our objectives are clearly defined: to confirm intrauterine pregnancy, to confirm viability, to assess for free fluid. That's it. A little bit about the patient's clinical details, how many pregnancies and births they've had, when their last period was, what blood group they are, what their beta HCG is, and what their history is. This side here is all useful reference information. How many weeks pregnant they are, what their beta HCG range can be, what the pregnancy should look like, and these are all to scale. How big the gestational sac is with increasing weeks, how big the crown rump length or the embryo is with increasing weeks, and some notes that are useful. And the key questions that we ask in this report are, firstly, were the views adequate or inadequate? Is there an intrauterine pregnancy? Is the intrauterine pregnancy confirmed or not? Is the pregnancy viable? Yes or no? Is there free fluid? Yes or no? And those are the key questions. We can then write a conclusion and sign it. So that's the report that we'll go through in a little bit more detail. Level 2 ultrasound takes a lot more learning, and instead of doing 25 scans, you're doing 250 scans to develop this sort of level of knowledge. And obviously you continue to increase and improve your ultrasound knowledge until people have done 2,500 or 3,000 scans, and then it takes even longer to improve. But people who've done that much ultrasound can determine a lot more complicated things about intrauterine pregnancies, about the uterus, about the cervix, and about ovaries that in level 1 we're not expected to know. So let's get on to something interesting. Let's do normal early pregnancy, okay? Most of us know about very early.
to all my dreams.
There we have it. MRI.
You're my sun, my moon.
Takes its course. So we traditionally date early normal pregnancies from the date of the first day of the last period. So I think I've got that wrong there, but our dating should be from the first day of the last normal period, as we know. So 2 weeks pregnancy is actually when you ovulate and fertilization follows. So ovulation and fertilization is actually day 0 here. So fertilization, day 0. Then the fertilized egg comes down through the tube. You get first cleavage a couple of days later. Heads down. A week after fertilization, you still haven't implanted. It's just after this you get implantation of the blastocyst. So 3 weeks pregnancy is when you get implantation, although that's only actually 1 week or just over a week from fertilization. And then 4 weeks is when the first period is missed and women start developing pregnancy symptoms and they realize that they're pregnant. So 4 weeks pregnancy is the first that generally women find or know that they're pregnant. So here we go, early pregnancy again. This is another little, this is an internet resource, I'm afraid, but it's quite a useful thing. Here you can see the female reproductive organs. The male's obviously done his business. Here come the little fellas, and not quite as amusing as the first episode, but here they come. We've got fertilization at day 0, so that's 2 weeks. Then down we come, and the first cleavage is 2 days after that. 4 days after that, we get the formation of a morula. Then this is called a blastocyst, which implants at 3 weeks. Okay, so 3 weeks implantation. This is really important, so sit back, concentrate. We're talking about beta-HCG now, okay, the pregnancy hormone. Beta-HCG is normally less than 5 in a non-pregnant woman. It's first positive on a urine dipstick when it's about 50, and it first reaches 50 at about 4 weeks, so about the time of the first missed period. So generally a woman first can tell she's pregnant on a urine test when she misses that first period, when actually by our dating system she's 4 weeks pregnant. Since conception she's 2 weeks pregnant. So it's 2 weeks since conception, but on a urine dipstick you can first tell you're pregnant. Okay? Other important thing is that the beta-HCG doubles every 48 hours, pretty reliably up to 8 weeks in early pregnancy. And the general rules are it must increase, although we say it doubles every 48 hours, occasionally it doesn't quite double, it must increase by at least 66%. If it doesn't increase by 66%, there's a problem with that pregnancy. This is another really important thing, the discriminatory zone. It's the level of beta-HCG when you should see something in the uterus on ultrasound. So TV stands for transvaginal ultrasound and TA transabdominal. When your beta-HCG is 1500 international units per mil, you should, on an ultrasound, be able to see something in the uterus. If it's 6000, which is only actually 4 days later, because if the beta-HCG doubles every 2 days, got 1500, 2 days later it should be 3000, 2 days after that it should be 6000. So 4 days after you see something transvaginally, you should be able to see something transabdominally. Now that's using modern ultrasound equipment. So obviously the discriminatory zone depends on the position of the uterus. If it's close to the abdominal wall, it's easier to see. It also depends on the experience of the operator. It also depends on how good the ultrasound machine is. Alright, so let's get down to what happens after that first positive pregnancy test. Beta-HCG is really useful in that it doubles every 2 days with a normal pregnancy. But a one-off level isn't so useful because you can see at 4 weeks pregnancy, the range is from 40 to 4,480, and that's in our hospital, and it varies from laboratory to laboratory. But there's a huge range in beta-HCG in all sorts of normal pregnancies. It's the trend that's the most useful thing, not a one-off beta-HCG. By the 4th week, that pregnancy is well implanted into the endometrium. You get a decidual reaction and a thickened endometrium. And on an ultrasound, you get a little blob. So at 4 weeks, and in fact, or 4 weeks and 3 days, you have a 2 millimeter gestational sac, tiny little thing. Around it, you have an echogenic rim and what we call a double decidual ring. You can see that you've got this brighter white bit and then a little dark bit there and then a brighter white around there, and that's called a double decidual ring. The problem is that it just looks like a little cyst, doesn't it? And although that is typical, and this one is actually a gestational sac, it's very easy to get that wrong. And a pseudo-sac of ectopic pregnancy or other little cysts in the endometrium can look the same. And so you can make a mistake. You shouldn't just look at that and go, oh yeah, that's a gestational sac. It could be, but it could be other things too. Very, very useful tip is that a gestational sac grows a millimeter a day. Very useful, because if you see this at 4 weeks and 3 days and it's 2 millimeters, a week later it's going to be 9 millimeters. Another useful thing is that the fetal pole also grows a millimeter a day. Now, in our reference part of the early pregnancy report, here is the weeks I've mentioned, 4, 5, 6, 7, 8, 9 weeks. Here's what it looks like. The gestational sac, we say what it is at each week, and here it grows a millimeter per day for the first 8 weeks. Crown rump length grows a millimeter per day for the first 10 weeks. Useful stuff. Now, the 5th week, beta HCG is higher. The gestational sac's up to 5 mils, because at 4 weeks and 3 days it's 2. A bit after that it's 5 millimeters. But the embryo itself is the size of a poppy seed. It's too small to see with ultrasound. But what we do start seeing is a yolk sac. So here's a gestational sac. We start seeing the yolk sac inside it. This is a picture of 5 weeks and 5 days. The gestational sac here is 10 millimeters. You may see a double bleb, which is the yolk sac, and an amniotic sac. You may see a fetal heart at this stage, but the fetal heart rate initially is relatively slow, about 100 beats per minute. Also on the ultrasound report are some other tips. You should always see a yolk sac by the time the gestational sac is 10 millimeters across on a transvaginal ultrasound, and by 20 millimeters across on a transabdominal ultrasound. Here it is again, another 5-week pregnancy, and we're just starting to see a very, very early fetal pole, 5 weeks and 5 days. There it is. This is a video of a 5-week and 5-day scan, and you can see a yolk sac, and in fact if you look very carefully you can see the very first signs of a fetal heartbeat. Watch that. You can start seeing a slow flutter, about 100 beats a minute. Gestational sac, echogenic rim, double decidual reaction. Okay, that's the double decidual ring there. This is the gestational sac, this is the yolk sac, and right here you can see a slow fluttering. That's the first contractions of the fetal or embryonic heart. This whole big thing here is the uterus. Okay. Here, so we're up to about 5 weeks now. Here it says you should see a yolk sac by gestational sac 10 millimeters TV or 20 transabdominal. Now the 6th week. Okay, and again I've sought some of these from the internet, and I've given credit at the bottom to the places that I've got these pictures from. This is a real picture of a 6-week embryo. This is the yolk sac, this is the amnion developing here. This is the tiny little fetal pole, which is 3.5 millimeters long at 6 weeks. Again, a big range of beta HCG. Gestational sac at this stage is 12 millimeters. The fetal pole, 3.5 millimeters, about the size of a grain of rice. The fetal heartbeat around 100. What does that look like on ultrasound? This is what it looks like. So let's go back here. Yolk sac, fetal pole, 3.5 millimeters. Yolk sac, fetal pole, 3.5 millimeters. Grain of rice size, 6 weeks. Here's another one. Yolk sac, still got that nice double decidual ring, you see that? Echogenic, dark, echogenic. Gestational sac, yolk sac, fetal pole. Okay, so 6 weeks, that's what they look like. 6 weeks and 4 days, our gestational sac's up to 16 millimeters. Fetal pole is 7 millimeters. Some other tips, the fetal pole should be seen by the time the gestational sac is 16 millimeters by transvaginal and 25 millimeters by transabdominal. So what that means is, if you don't see a fetal pole when you've got a big gestational sac, it means there's a problem. It might be a missed miscarriage. That used to be called a blighted ovum or an embryonic pregnancy. The other important thing is that a fetal heart should be detectable by the time the fetal pole is 5 millimeters in length. So the crown rump length, you measure that from there to there. If that's more than 5 millimeters and you can't see a heartbeat, that pregnancy is probably not going to work. That's transvaginal. By transabdominal, the fetal pole needs to be 9 millimeters to show a heartbeat. Here we have a video of a 6-week and 4-day pregnancy. You can see here is a little 7 millimeter fetal pole. Watch carefully. You can see that heartbeat. The yolk sac on this case is just out of plane of this image. Okay, so we're up at 6 weeks. We've got the yolk sac, little fetal pole. Again, with more of those notes, the things I've just gone through about when we should see a fetal heart, when we should see a fetal pole. Okay, 7 weeks. Beta HCG a bit higher still. Gestational sac, 7 millimeters bigger than it was a week ago. Fetal pole, 7 millimeters bigger than it was a week ago. Fetal heart rates increased to about 140. Now, I talked about the grain of rice at 6 weeks. It's a baked bean by the time it's 7 weeks, and this is what it looks like. Here is the ultrasound. All these ultrasounds are from my patients, but obviously the images of embryos I've taken from the internet, and thanks to the people that provide them. I've done all these pictures with different ultrasound machines, some good, some bad, deliberately, so you can get a picture for what it's like. Okay, so there's our little baked bean, yolk sac, gestational sac, baked bean. Here's another one. It looks remarkably consistent. Pregnancy, the great thing about early pregnancy is it develops absolutely routinely if it's normal. This bag around the crown rump or the fetal pole here is the amnion. Okay, so 7 weeks. This is what it looks like. Yolk sac, baked bean, 9.5 to 10 millimeters long. Okay. 8 weeks. Here we have it. Limb buds start appearing. And crown rump length is now up to 16 millimeters, and that's from here to here. Okay, 16 millimeters. There's your 8-week pregnancy. And there's an ultrasound of the same. Starting to get little limb buds here, arms, legs, rump, crown. Okay, that's an 8-week pregnancy. Here's another one. Watch this little heartbeat. Yolk sac still there. Head this end. Little limb buds here. Heart in the middle, ticking away. That's a normal 8-week pregnancy. Okay. 8 weeks, starts looking a little bit like a baby, 16 millimeters long. Now, this is where it suddenly starts looking really like a baby, 9 weeks, okay? Starting to get a lot bigger, 23 millimeters long. Here it is, head, body, little legs, a 9-week pregnancy. Another one. 9 weeks, starts looking like a baby, 23 millimeters long. Okay. From then on, it just gets bigger, looks more and more like a baby. 10 weeks, here we have it. 12 weeks, here we have it. Here's our nice little nose, lips, chin, and we're starting to see a proper looking fetus. Here are those pictures again at 6 weeks, 7 weeks, 8 weeks and 9 weeks, again all to scale. And I've put the same thing with ultrasound. The 4-week, 2mm, 4.5-week, 2mm gestational sac, which then develops a yolk sac, then develops at 6 weeks this fetal pole with a heartbeat, then baked bean size, 7 weeks, 8 weeks, limb buds happening, 9 weeks, looks like a baby, 12 weeks, everyone says, oh. Okay, so that's normal early pregnancy. Now, how do we integrate that into our clinical algorithms? Diagnostic dilemmas tend to happen early in pregnancy, before 7 weeks. Why is that? Well, because after 7 weeks, ultrasound is easy. You know, it's either, if someone's more than 7 weeks pregnant, you either see something and there's a normal pregnancy, or it's obviously abnormal. It's between 4 weeks and 7 or 8 weeks that things can get difficult. And that's because ultrasound isn't so definitive in early pregnancy. But ultrasound is only one part of the clinical picture. We're clinicians. And the beauty of having ultrasound in our hands is that we can integrate the findings into our clinical picture. And that's really important. We've mentioned the discriminatory zone, the level of beta HCG at which you should see something in the uterus. If your beta HCG is above the discriminatory zone, so you've got high beta HCG, you should see something in the uterus. If you don't, what does that mean? That means it could be an ectopic pregnancy. It could be a pregnancy that isn't in the uterus. Or it could be a complete miscarriage. So the patient has actually had a miscarriage and their beta HCG hasn't come down yet. Occasionally, twins or multiple pregnancies can have a very high beta HCG, but the gestations are so small still that you don't see anything. And molar pregnancies can also have, or gestational trophoblastic disease can have very high beta HCGs. This is the initial assessment algorithm we mentioned before, and we're going to go through it in detail. The first thing is to work out the dates, see where you are. Patients usually can tell you when their last menstrual period was. Sometimes they can tell you when their date of intercourse was, or they ovulated, or the date of the pregnancy symptoms, but these aren't particularly reliable symptoms. The ones that are reliable generally are the date of the first positive beta HCG. So when they first checked their urine pregnancy test and it was positive, that means they were at least 4 weeks pregnant. They could have been more pregnant then, but if they said 2 weeks ago I checked my pregnancy test, it was positive, that means that 2 weeks ago they were probably 4 weeks or more pregnant, which means they're now 6 weeks pregnant, which means from what we've just gone through, we should see a yolk sac with a little fetal pole and hopefully a little heartbeat. The other thing that's reliable is previous ultrasound examinations in that pregnancy. So, as I mentioned, more than 7 weeks should be easy. You definitely see an intrauterine pregnancy, it should have a heartbeat. If you don't see that at more than 7 weeks, you've got a problem. If it was an empty uterus, it could be an ectopic or a miscarriage. If they've had a miscarriage, it's usually obvious. They can tell you they've been bleeding heavily, they've passed some products. Not too tricky. If the ultrasound shows heterogeneous or varied uterine contents, it could be a miscarriage, there could be lots of clots in the uterus, it could be a pseudosac of an ectopic pregnancy, which is where you get some bleeding into the endometrial cavity with an ectopic, or it could be gestational trophoblastic disease, which is classically a heterogeneous and echogenic endometrial content. So let's go back to this and let's look at step 1. Now with limited ultrasound, you might get things wrong. So if a patient has high risk features, so obviously if they're hemodynamically unstable, you've got to worry about an ectopic. You refer immediately, okay? Get them to see someone who knows about ultrasound and is good at managing early pregnancy problems. So in unstable, get help straight away. If they've got really severe pain, again, they may have something bad wrong with them. Don't mess around with ultrasound that may or may not be useful. If they're really badly pain, analgesize them, then you may be able to do an ultrasound, but refer. We can't get those ones wrong. If they've got really heavy bleeding, then they need to see someone who's good at managing early pregnancy and able to do a D&C for a miscarriage or assess the patient appropriately for what's going on. And that may or may not be you. If they're an IVF patient, they should also get referred if they've got pain or bleeding in early pregnancy, and the reason is that IVF patients have a higher risk of heterotopic pregnancy. That's where they have an intrauterine pregnancy and a pregnancy that is ectopic at the same time. And so you may even, in them, see an intrauterine pregnancy and think, oh great, but numbers vary between 1 in 100 and 1 in 300 actually has a second ectopic pregnancy at the same time. Also, if your ultrasound shows a lot of free fluid or more than a trace of free fluid, it's probably worth referring that patient for an expert scan and management. So the first step is to look for the high risk features, okay? You've assessed them, you've worked out what their gestation is. Do they have really high risk features? If they do, so hemodynamic instability, severe pain, heavy bleeding, IVF patient, more than a trace of free fluid, so a significant amount of free fluid, they get referred for expert scan and management. Easy, okay. Step 2, is it a definite miscarriage? Because if it's a definite miscarriage, it's sad, but that patient is unlikely to have long-term problems from it, and they're not going to suddenly drop their bundle on you with any luck. But what's really important is that you're sure that it's a definite miscarriage. A lot of patients present and say, oh yeah, I've had bleeding, I've got clots, and you think, oh yeah, it's a miscarriage, but they really need, and you need to see sac or products. So this is a gestational sac which has been passed. This is the sort of placental tissue. This is about a baked bean size 7-week embryo that's in here. If that comes out, it's a definite miscarriage. There's no doubt. That patient doesn't have an ectopic, unless it's one of those heterotopics I mentioned, but that patient doesn't have an ectopic pregnancy. It's a definite miscarriage. Blood clot alone, not enough to say it's a definite miscarriage. So if they're a definite miscarriage, they can have it explained to them. It's sad. They should have normal future pregnancies. They can go home with advice, return if they get really heavy bleeding, if there are other concerns, evidence of infection, and then they can get a formal scan in the next 48 to 72 hours if it's indicated to look for retained products of conception. So, are there high risk features? Refer. Is it a definite miscarriage? Explain. Is it a definite intrauterine pregnancy? Now that is where you get to use your ultrasound, and in fact where most of the patients will be when they present to you with pain and bleeding in early pregnancy. The important thing about defining a definite intrauterine pregnancy is that the little sac, an empty sac alone, is not enough. Remember that 4-week little tiny sac that is a gestational sac can be confused with a pseudosac of ectopic or another cystic endometrial structure. So what you really need to say it's a definite intrauterine pregnancy is a yolk sac. If you can see a fetal pole and fetal heart as well, even better. But to say it's a definite intrauterine pregnancy, you have to at least see a yolk sac. If you do, that's great. They can be discharged, see them again in 2 to 3 days with a formal scan. Again, even these patients should always be told if they get heavy bleeding, severe pain or signs of infection, come back. Okay, so most patients will fit into those categories. There are other patients where things get more complicated. Pain and bleeding in early pregnancy, you do an ultrasound, shows they've got an empty uterus and their beta-HCG is high, above the discriminatory zone. So empty uterus, high beta-HCG, probably an ectopic, unless they've had a complete miscarriage, but usually they tell you that they passed a big lump, there were products there, that's a miscarriage. So probably an ectopic pregnancy, occasionally twins, where you've got small gestation sacs just too small to see, but their beta-HCG is extra high. But usually, an empty uterus, a high beta-HCG is an ectopic, and those patients should get referred somewhere else immediately. So that's not too tricky. Empty uterus, high beta-HCG, refer. The next step, empty uterus or a small sac or heterogeneous content. So that means you have a look, it's not clearly a definite pregnancy, so there isn't a yolk sac. It's what we call a pregnancy of unknown location, a PUL. It could be an early intrauterine pregnancy, either empty uterus because it's less than that 4 weeks and 3 days when you start seeing stuff, or a small empty sac, so that little sac, which you think's a gestational sac, but it might still be something else. It could be a stable ectopic. It could be a miscarriage, particularly if there's heterogeneous content, you've got clot in the uterus. And it could also be that molar pregnancy. So what do you do with this group? They're stable. We've already said they're not hemodynamically unstable because that's an exclusion criteria, step 1. They're stable, they've not got terrible pain, they've not got huge amounts of bleeding, but they've got a low beta HCG. They could be early pregnancy, they could be ectopic, they could be miscarriage. You're not sure? Well, you're going to have a look at them in 48 hours time. Okay? You do a repeat beta HCG in 48 hours to see what's happening to that, and you get a formal scan. And you also give them advice. They should come back again if they get pain, bleeding, or evidence of infection. The final group is the group who's got an empty sac or heterogeneous content and a high beta HCG. Okay, well there's diagnostic uncertainty. It could be an early intrauterine pregnancy. We are seeing something in the uterus, an empty sac. Okay, so if it's a small empty sac, it could be that 4 week and 3 days before the yolk sac arrives. Okay, it could be a missed miscarriage. Now, and that is if the gestational sac is very big, so more than 20 millimeters transabdominally, empty sac. It's probably an 8 to 10 week pregnancy that is a missed miscarriage. It could be, but this level of ultrasound education, you can't really diagnose that. Okay, it wasn't one of our initial objectives. It could be a miscarriage with a heterogeneous content and a high beta HCG. It could be a molar pregnancy, and it could still be an ectopic pregnancy. If that empty sac is actually a pseudo sac with a high beta HCG, it could be an ectopic. Our recommendation for this group, where there's uncertainty, but they're stable, they've not got terrible pain, they've not got really heavy bleeding, is again repeat beta HCG and see them in 48 hours, ideally with a formal scan. And again, with advice to come back if they do develop instability, severe pain, or heavy bleeding. So remembering, beta HCG doubles every 48 hours, okay, or at least increases by 66% in 48 hours. It halves in 48 hours after a complete miscarriage. So this is very useful. Those last two groups that we weren't quite sure what it was, we're going to see again with the repeat beta HCG in 48 hours. If it's a normal pregnancy, it doubles. If it's a complete miscarriage, it halves. With an ectopic pregnancy, though, it tends to rise slowly. All right. And we've mentioned that the beta HCG is often very high with multiple pregnancies and molar pregnancies. So here's our initial assessment algorithm. We've got these two groups that we're going to repeat the beta HCG and see again in 48 hours time. This is the 48-hour follow-up algorithm. Okay, so you get them back in 48 hours, they've had a formal ultrasound, and they've got another beta HCG level. Often the formal ultrasound findings are definitive 48 hours later. Everything is 2 millimeters bigger 48 hours later if it's all going well. The formal ultrasound may show you a definite intrauterine pregnancy. Great, discharge the patient. It may say there's a definite miscarriage with some products left behind in the uterus. Okay, well they may need further management with misoprostol or DNC. If you don't know what to do, you need to seek expert advice. Okay, so a missed or incomplete miscarriage, or it may show a definite ectopic. Again, now we know what to do, that's fine, we seek expert advice. They may get methotrexate, they may get a laparoscopy, so ectopic. But in some of those patients you review at 48 hours, ultrasound won't be definitive, and it won't be definitive because there's an empty uterus. Now in this group, all these patients came back because they had an empty uterus or an abnormal intrauterine finding. In this group, the beta HCG trend is the most useful thing. So they've got an empty uterus, the beta HCG has doubled. Well, it's probably a normal intrauterine pregnancy because the beta HCG has done what we want it to do. If the beta HCG is above the discriminatory zone, we then should start seeing something in the uterus. So we should follow these patients up until then. If their beta HCG has doubled and it's now above the discriminatory zone and you still can't see anything in the uterus, it is probably an ectopic pregnancy and you should seek further advice. So first group with an empty uterus, beta HCG doubled, probably a viable pregnancy. Second group, empty uterus, beta HCG halved, they've probably had a complete miscarriage. They can go home. With an empty uterus and a slowly trending down beta HCG, that could be a miscarriage, and that's the most likely thing. A miscarriage, possibly incomplete because beta HCG is going down slower than usual. Okay, they should get followed again 48 hours later. The other thing that this could be is a spontaneously resolving ectopic pregnancy, because sometimes an ectopic in the tube forms and then just doesn't grow, and the beta HCG just gently trends down by itself, and you can actually just follow it until the beta HCG is down to 10 without doing anything. But in this group, where the beta HCG is going down slowly, you should seek expert advice. The final group is those who have an empty uterus and the beta HCG is going up slowly. So not enough to say it's a normal, viable intrauterine pregnancy. The most likely diagnosis in that group is an ectopic. And in them you need to seek expert advice, and they may need methotrexate or laparoscopy. So all a bit complicated, isn't it? But if you use these algorithms, it all works itself out. Final thing just to touch on again is the early pregnancy ultrasound report. Again, patient data, reference material, key questions. Were the views adequate or inadequate? With an intrauterine pregnancy, is it confirmed or not? How big is the gestational sac? Was there a yolk sac seen? And you have to see a yolk sac to say it's an IUP that's confirmed. If you just see a gestational sac, but no yolk sac or fetal pole, it's not confirmed. Was there a fetal pole? Viability, and that means, was there a fetal heartbeat? Okay, viability confirmed, what was the fetal heart rate? Free fluid, was it present or not present? And if so, how much was there and what did it look like? And we'll get to that in our next lecture. So, this lecture is complete. We've gone through the training requirements, the broad objectives of level 1 early pregnancy ultrasound, what happens in normal early pregnancy, how to integrate your ultrasound into your clinical algorithms, and the early pregnancy ultrasound report. There is the algorithm which you can always print out and look at it in more detail, and there's the follow-up algorithm 48 hours later.